Good afternoon, everyone, and thank you for joining us, the last National Bleeding Disorders Foundation, formerly National Hemophilia Foundation, Wednesday webinar of the year. My name is Fiona Robinson, and I am the series host. In today's webinar, we will hear about advancement in bleeding disorders care. The webinar is being recorded and will be available to the community beginning on Friday, December 22nd. We encourage you to ask any questions you may have today. You can ask your questions by using the Q&A feature at the bottom of your screen at any time. We will monitor these questions as they come in, and following our speaker's presentation, we'll put your questions to them. Today, we are joined by Dr. Amy Shapiro, a pediatric hematologist and the Chief Executive Officer and Co-Medical Director of the Indiana Hemophilia and Thrombosis Center. I'd like to thank Dr. Shapiro for joining us today, and I will turn things over to her now to get us started.
Thank you, Fiona, and thank you to the National Bleeding Disorder Foundation for inviting me to speak today on advancements in hemophilia care. Over the last 2 decades, we've been privileged to witness major innovations in hemophilia treatment that are progressing at an astounding pace. I will cover a variety of areas that contribute to these advancements as listed here. Our review begins with therapeutics that replace the deficient clotting factor to restore hemostasis. This area includes significant advancements to extend the half-life of infusion products, followed by the development of novel factor VIII mimetics and gene therapy. I will also highlight new or emerging non-factor therapies, followed by the use of technologies to improve education, data monitoring, and bedside diagnostics, as well as the use of artificial intelligence to advance care. Finally, I will wrap up our discussion looking at the broader landscape, including the importance of health equity in delivering these innovations to all affected individuals throughout the world. Treatment strategies for hemophilia evolved along parallel lines, including advancements in replacement products themselves, as well as the therapeutic regimens utilizing them. We have moved from treatment of bleeding episodes once they have occurred, termed on-demand or episodic therapy, to an understanding that bleed prevention or prophylaxis represents optimal care. To reduce treatment burden, replacement therapies have evolved using a variety of mechanisms from standard to extended half-life products. Treatment has also evolved outside the use of modifications of the clotting factor itself to include the development of mimetics in factor VIII deficiency, rebalancing agents, and gene therapies. In sync with these developments, further technological advancements have emerged, such as new tools and devices, including point-of-care musculoskeletal ultrasound, mobile apps, and personalized pharmacokinetic dosing, as performed through the WAPS Hemo application. As we strive to achieve optimal outcomes, we must be cognizant of how healthcare is made available and delivered to all patients with bleeding disorders. We need to be mindful of health equity and address racial, ethnic, age, and gender biases within our regions, countries, and throughout the world. We are, as an international community, working together to address disparities in healthcare resources that exist worldwide. With optimal access to therapeutic modalities, treatment goals now include early start of long-term prophylactic therapy with a focus on patient-reported outcomes to support a high-quality active life. Product expansion with different pharmacokinetics has allowed providers to individualize prophylactic regimens targeting desired factor levels and infusion frequency. These patient-specific regimens permit providers to achieve improved outcomes while focusing on patient health needs and life goals, which are often impeded by a spectrum of challenges. Under the best of circumstances, all these strategies and innovations are interwoven to support achievement of the ultimate goal of a bleed-free life. With the support of new technologies and more effective treatments, we are now seeing bleed prevention and control across the lifespan in the majority of patients. Bleed prevention also includes the need for adequate planning to allow hemostatic coverage for needed procedures. Indeed, focus is now required to address many of the more prevalent age-related comorbidities commonly observed in the general population that have emerged in bleeding disorder patients, such as malignancies, cardiovascular disease, obesity, hypertension, and chronic renal disease, and more. By preventing bleeding episodes and target joints, we anticipate improved joint health, which ultimately will translate to a higher quality of life. Outcome assessments and clinical trials now embrace the evaluation of quality of life, along with annualized bleed rates, underscoring the importance of these overarching therapeutic goals to evaluate new therapies and strategies. Next, we will focus on current and investigational therapies, including factor replacement, mimetics, gene therapy, bypassing agents, and inhibitors of coagulation targets. Presently, in the United States, there are 13 recombinant factor VIII replacement products available for patients without an inhibitor, 5 of which are considered extended half-life therapies. Here we have listed these products with the approximate half-life in hours for both the adult and pediatric populations. In addition, there are several further innovative therapies in development. There are currently 6 recombinant factor IX replacement products available for patients without an inhibitor, 3 of which are considered extended half-life therapies. These products are shown here with their approximate half-life, again in hours, for both the pediatric and adult populations. A variety of strategies to prolong half-life have been employed for both factor VIII and factor IX, such as pegylation, fusion with the Fc domain of immunoglobulin G, or with albumin, and single-chain covalent bonding. The majority of factor VIII extended half-life products have a 1.3 to 1.7 extension or increase over standard half-life products. Although factor VIII half-life extension strategies have been successful, they were limited by the sealing effect of its carrier protein, von Willebrand factor. Therapeutic strategies have been developed to overcome this limiting effect, specifically the recombinant factor VIII Fc VWF X10, a B-domain deleted Fc fusion recombinant factor VIII protein with a VWF stabilizing D' D3 domain that prevents endogenous von Willebrand factor binding, and 2 biodegradable polypeptides, or X10s, to further extend the half-life through steric shielding, all of which have resulted in a reported half-life that is now 3 to 4 times that of standard half-life recombinant factor VIII. This product is now available. In contrast, the ability to extend the half-life of factor IX therapies has been very successful, with a 4 to 6-fold increase over standard half-life therapy, thereby allowing infrequent prophylactic infusions ranging from weekly to up to every 2 weeks, depending on the individual patient half-life, the desired trough, age, and activity. Recent research efforts have focused on subcutaneous delivery, achieved by adding X10 polymers to the recombinant factor IX Fc Padua variant molecule, or using a factor IX variant with 3 amino acid substitutions, resulting in increased potency compared to endogenous factor IX. Factor VIII mimetics have provided a transformational change in hemophilia care. The first such agent is emicizumab, which was FDA approved in 2017 and 2018 for treatment of factor VIII deficiency with and without an inhibitor, respectively. This mimetic is a humanized bispecific monoclonal antibody that substitutes for the scaffold effect of factor VIIIa by bridging factors IXA and 10. It is administered subcutaneously with a flexible dosing schedule and a long half-life of approximately 30 days. This agent has significantly reduced treatment burden, most notably in patients with inhibitors and those with difficult venous access and in infants. It has also decreased the annualized bleed rate as compared to factor prophylaxis in non-inhibitor patients and provided inhibitor patients the ability to achieve improved prophylaxis, a major advancement in their care. Next generation factor VIII mimetics are in development. An example is Mimate, which is currently in phase 3 clinical trials. This agent has a reported 15-fold increased potency as compared to an analog of emicizumab, which may allow for lower dosing volumes. In addition, emicizumab is NXT007, another second-generation form of emicizumab, whereby the heavy chains were optimized, the non-common light chains were newly selected from a Phage laboratory, and there was the addition of increased binding activity against the FcRn portion of the molecule. Innovations in gene and cellular therapy have generated intense excitement. Adoption of viral vectors derived from mammalian viruses that have naturally evolved to deliver their genetic material into cells and tissues have been employed. Adeno-associated viral or AAV vectors are derived from wild-type AAV, which is a non-pathogenic, weakly immunogenic, and replication-deficient virus. AAV vectors can deliver a therapeutic transgene up to 5 kilobases into both dividing and non-dividing cells. These vectors contain minimal wild-type viral sequences, but their pathogenic, replicative, and structural viral genes have been replaced with the therapeutic gene cassette. The corrective gene is delivered to the patient's target cell by the viral vector with specific organ tropism. There remain long-term unknowns, including the risk for insertional mutagenesis, felt to be low, as the majority of AAV vector genomes do not integrate into the host genome. However, deep sequencing reveals that integration of the AAV genome can occur in the liver. In addition, as the expression cassettes for factor VIII and factor IX are episomal, treating a patient too early in life may result in a decline of factor activity due to cell division. Treating individuals with pre-existing coagulation factor inhibitory antibodies requires further research, as does some products, depending on the viral capsid antibody titer. In addition, further work remains to be done to define the optimal immunosuppressive therapy and regimen to prevent transgene loss. Gene and cellular therapies for the treatment of persons with hemophilia A are in various stages of development. The use of adeno-associated virus vectors allows for hepatic tropism, non-pathogenicity, and the ability to transduce dividing and non-dividing cells. There are numerous trials for gene and cellular therapies for hemophilia in various stages of development. The next two slides review many of the gene therapy trials with the vectors utilized and the sponsor. Gene editing technologies such as zinc finger nucleases, CRISPR-Cas9, and TALENs are also progressing. Cellular therapy is also being explored, where cells are transduced ex vivo and transferred back into the host. I will highlight later 2 approved gene therapy agents. Here are highlighted several investigational gene therapy trials in patients with hemophilia B, most utilizing an AAV vector with the factor IX Padua transgene. The Padua variant is utilized due to its increased activity as compared to wild-type factor IX. These trials are ongoing. Some have demonstrated a 5 to 8-fold higher factor IX activity level than previously achieved with wild-type factor IX in the transgene. Let's go into the 2 approved gene therapies available in the United States. The first is Hemgenix for hemophilia B, approved in November 2022. To be eligible to receive this agent, you need to be greater than 18 years of age, without history or presence of an inhibitor, using factor IX prophylaxis, or have current or historical life-threatening bleeding, or have had repeated spontaneous bleeding events. Your AAV anti-AAV titer should be less than 678. Other issues impact treatment eligibility, including the individual's liver health, alcohol use, their ability to adhere to the follow-up regimen and the use of immunosuppressives after treatment, their psychosocial status, their cardiovascular disease status, HIV status, current medications, etc. The current dose administered is 2 × 10⁻³ genome copies per kilogram. Endogenous factor IX activity over 18 months after treatment in the full analysis population is shown here. Factor IX activity from the one-stage assay based on the activated partial thromboplastin time is shown. The chromogenic substrate assay reveals a lower factor IX than the one-stage assay. The one-stage factor IX assay is 2 to 3 times higher than the chromogenic, but this is due to insufficient factor X content in the chromogenic reagent mix. You can see by this graph that the factor IX levels remain fairly stable over the 18 months reported. Reported for hemogenics and publications include 54 patients whose levels were less than or equal to 2% and ages 9 to 75 years. The average factor IX level achieved was approximately 41.5% at 1 year and 36.7% at 2 years. There were some adverse events that were reported. One individual prematurely discontinued due to an infusion-related adverse event. He only received 10% of the planned dose. There was one individual who died from urosepsis. He was 75 years at enrollment and 77 years at demise. This was not related to the gene therapy. One individual developed hepatocellular carcinoma. This individual, upon deep sequencing of the actual tumor biopsy as well as normal liver, was felt not to be related to the gene therapy product. 24 of 54 patients enrolled, or 44%, developed abnormal liver function tests. 9 of these, or 17%, were treated with steroids for a mean duration of about 80 days, plus or minus approximately 30. Liver enzyme increases to above the normal limits or to twice individual baseline in the first 3 months were considered for use of implementing immunosuppression. Of the patients treated, 96% discontinued prophylaxis from day 21 through month 18. 2 required prophylaxis when their factor IX activity levels decreased below 5%. One of these individuals is the individual who only received 10% of the dose, and one individual had an anti-AAV titer of greater than 678, which is the reason for that titer being one of the exclusion criteria for patients with the clinical medication. One additional patient required prophylaxis for a defined period of time. Before treatment, 21 participants, or about 39%, had a detectable neutralizing antibody against AAV5, meaning that their titer was at or above the limit of detection of 7 through this test. The relationship between 18-month factor IX activity level and pre-treatment AAV5 neutralizing antibody titer is shown here. Up to a titer of 678, no correlation was seen between a participant's pre-existing AAV5 neutralizing antibody titer and the participant's factor IX activity at 18 months post-treatment. Of the 2 participants with factor IX activity less than 5% at month 18, one had a pre-existing neutralizing antibody titer of 3,212, and the other, the participant with a pre-existing neutralizing antibody titer of 198, received only 10% of the dose. The mean factor IX activity was 31% and 39.9% for participants with and without pre-existing anti-AAV5 neutralizing antibodies, respectively, at 18 months post-treatment. This difference was not statistically significant. The second medication or gene therapy that is available now in the United States is Roctavian for use in factor VIII deficiency. This was approved in June 2023. Eligibility for this agent is greater than 18 years of age, severe hemophilia A, no presence or history of an inhibitor, and an anti-AAV5 negative titer completely. This is in contrast to the hemogenics, where you can be positive up to about 700. Other issues impact treatment eligibility, as previously discussed with hemogenics, and these are listed here. Also, the use of efavirenz and isotretinoin are problematic in this population, as it can cause loss of transcription of the transgene and should be avoided. The dose administered is 6 × 10 to the 13th genome copies per kilogram. The following slides report factor VIII levels via the chromogenic assay. Interestingly, recombinant factor VIII B domain deleted factor VIII levels by use of an exogenous product are via the one-stage assay less than the chromogenic assay. However, with Roctavian, the one-stage assay is 1.6 times higher than the chromogenic assay. Factor VIII activity per the chromogenic assay is shown here on this slide over time. In panel A on the left shows the mean factor VIII activity for the intention to treat population, which included 132 individuals, and the mean intention to treat subgroup that was dosed and had greater than or equal to 3 years of follow-up, and that includes 17 patients, and that is at the bright blue at the tail end of the curve on the left. The mean intention to treat population included all HIV negative participants who received Roctavian. Panel B on the right shows individual factor VIII activity levels for the intention to treat subgroup who were dosed and had greater than or equal to 3 years of follow-up. Those are 17 individuals with 17 individual curves on the right. And as you can see, there's quite a bit of variability in terms of the level achieved, and the level does fall over time. This table shows the mean and median factor VIII activity for the intention to treat population at the end of years 1 and years 2 by both assays, one stage and chromogenic. Year 1 values are from week 52. Year 2 values are from week 104. Regardless of the assay utilized, the levels do demonstrate a decrease over time. This is a report that is published in the literature by Dr. Johnny Malangu and the study team on the use of Roctavian. And what this report shows or reported is that the factor VIII levels remained in the mild range for at least 5 years post-gene therapy transfer. 6 patients resumed regular prophylaxis, 5 used factor VIII, 1 used emicizumab. 88.8% experienced a total of 385 liver enzyme elevations that qualified as an adverse event per the previously described criteria within the study, which was 1.5 times baseline or greater than the upper limit of normal. And at those points, steroid treatment was considered. 79.1% and 29.9% of participants used corticosteroids and/or nonsteroidal immunosuppressants for the treatment of these ALT elevations post-infusion. Looking closely at the FDA package insert, further data is available. This revealed that 134 patients were included in the FDA's analysis and consisted of 2 groups, a rollover group, 112 patients, and those who were directly enrolled into the study without pre-treatment observation, and that included 22 patients. The rollover population of those individuals, 107 or 96% had some form of what was considered hepatotoxicity, defined as a liver enzyme elevation greater than or equal to 1.5 times baseline. 92 or 82% needed to take steroids for approximately 6 months. 39 or 35% needed to take a different immunosuppressive regimen with or instead of steroid treatment. In terms of the response of the total population, In 6 individuals, the FDA reported no response, meaning a level less than or equal to 3%. 23 lost a response, and that was including follow-up from 1 to 4.3 years. So in total, 29 of 134, 21.6%, either had no response or lost efficacy, defined again as a factor VIII level less than 3%. Now let's touch on some additional considerations in gene therapy. Current limitations for the majority of gene therapy constructs include age, eligibility, presence of pre-existing vector immunity in some, presence of current or past history of an inhibitor, variable response noted in some trials, and the need for close monitoring and strict adherence to post-gene therapy administration, for example, laboratory evaluations and use of immunosuppressives to assure that transgene delivery and maintenance is achieved. Also, for patients who have lost the transgene or experienced an inadequate response, the ability to retreat is unknown. Additionally, young children are not currently candidates for this therapy due to the expected hepatic growth and subsequent transgene dilution. Potential risks, which at present are not well defined, include vector impact on non-targeted cells, the potential for integration and possible malignancy, which is considered small but is a potential, liver toxicity, and potentially exposing others to the vector via vector shedding. Further unknowns include duration of expression, long-term side effects, some of which are previously mentioned, cost, safety, and potential need for a mechanism to redose, and the potential to use gene therapy to tolerize patients with inhibitors. Now let's turn to current agents for use in inhibitor patients, as well as those in development that work through targeting the coagulation factors that downregulate clotting to rebalance coagulation to promote increased clotting despite decreased factor VIII or IX, either with or without an inhibitor. Here we turn to bypassing therapies for patients with inhibitors. And although some of these products have been around for a long time, they are worth mentioning. FIBA was the first therapy used for patients with hemophilia with inhibitors that is still currently available. It was initially approved in 1986 and in 2013 for routine prophylaxis. It is approved for hemophilia with an inhibitor for control and prevention of bleeding episodes, perioperative management, and for routine prophylaxis to prevent or reduce bleeding episodes frequency. Novo-7, also known as Eptigac alpha, was approved in March 1999. It is indicated for adults and children with hemophilia and inhibitors for control of bleeding episodes and perioperative management. It is the preferred product for patients on the factor VIII mimetic Hemlibra and for many hemophilia B patients with inhibitors, especially those with prior anaphylactoid reactions to any factor IX containing products. It has had further approvals later for rare disorders, including factor VII deficiency and Glanzmann's thrombocytopenia. Eptigac beta, or 7-FACT, was approved in the U.S. in 2020 and is a bypassing agent to treat bleeding episodes in patients with hemophilia A or B with inhibitors 12 years of age to adults. It has a human amino acid sequence and is produced in the milk of transgenic rabbits. Its glycosylation profile is different from Eptigac alpha and as such has a high affinity for platelets and endothelial protein C receptor, which you'll also hear about as a target later. And the dosing of this agent is different than for Novo-7. Obizur was approved in the U.S. in 2014 for acquired hemophilia for treatment of bleeding in adults. It is a recombinant porcine sequence factor VIII. Its use has been reported but not approved in hemophilia A patients with inhibitors. Marzeptocog alpha was an investigational agent that was a modified factor VIIa with 4 amino acid substitutions engineered to increase the factor VII potency approximately 9-fold, designed for subcutaneous administration with a half-life up to 13 hours. However, the manufacturer halted the clinical development program as of November 2021. This slide is a graphic summary of the available procoagulant therapies as well as the investigational agents and their targets in the coagulation cascade. Note the numerous categories of replacement therapies for factor VIII and factor IX, as well as new products, including the mimetics, Super 5A, and other activated factor VII concentrates. This slide is further confirmation that hemophilia treatments have significantly advanced. In the next slide, we will look at other strategies that do not seek to replace the procoagulant protein, but rather target the naturally occurring inhibitors of coagulation. Strategies to rebalance hemostasis by targeting naturally occurring inhibitors of coagulation are under development. These agents are non-factor therapies that offset decreased or absent procoagulants and are administered subcutaneously. Current targets for these agents include the tissue factor pathway inhibitor, or TFPI, antithrombin, and activated protein C. These products are utilized to deliver prophylaxis and do not treat an acute bleeding event. These products are all currently investigational for treatment of hemophilia A or B with and without inhibitors. Tissue factor pathway inhibitors dampen the coagulation pathway by blocking activity of two of the major protease cofactor complexes, including tissue factor, factor VIIa, and prothrombinase. Concizumab and marstacimab both target TFPI and increase procoagulant drive. Serpine-PC is a serine protease inhibitor that binds to the endothelial activated protein C receptor and inhibits APC function, thereby allowing factors 5A and 8A to continue to generate thrombin. A small interfering RNA or siRNA targets antithrombin messenger RNA to suppress hepatic synthesis, thereby decreasing antithrombin levels and therefore thrombin inhibition. Fitusiran is an siRNA that utilizes this mechanism. This slide highlights the non-factor therapies with information derived from clinicaltrials.gov. Two agents, specifically the siRNA antithrombin and the anti-TFPI concizumab, have reported thrombotic events in their clinical trials, necessitating a pause with subsequent risk mitigation strategies before resumption. The siRNA antithrombin is administered infrequently, once per month or every 2 months, with a prolonged effect on antithrombin levels. In current clinical trials, concizumab is administered daily, while marstacimab is given weekly. They differ in half-life and TFPI domain affinity. Now let's turn to how technological advances have advanced care and outcomes through development of large databases, apps for remote data collection, and use of artificial intelligence. Hemophilic arthropathy represents a significant cause of morbidity and financial burden. Point-of-care musculoskeletal ultrasound is now accessible, fast, relatively inexpensive, and does not require sedation. It has the power to detect acute hemorrhagic events and to help differentiate these from chronic arthropathic pain, to evaluate the effectiveness of treatment and allow patients and providers to potentially tailor their regimens to intervene to prevent irreversible joint changes. Importantly, this modality requires rigorous operator training. In addition, protocols for data acquisition and scoring have not yet been globally standardized. The percentage of hemophilia treatment centers adopting this modality varies by region. A recent global survey reported about 50% of centers employing this technology, with perceived barriers including lack of trained personnel and time limitations. How can we improve point-of-care muscular ultrasound in the future? The results of the global survey and consensus meeting were published in Research and Practice in Thrombosis and Hemostasis in July 2021 and recommended development and use of standardized protocols globally to compare treatment regimens and outcomes. Tiered scoring, measurement systems that allow for comparison, and guidelines for ultrasound performance, interpretation, and reporting to ensure consistency should also be developed. Several mobile applications have been developed during the recent surge in technological innovations and utilized in hemophilia. Examples include work by the American Thrombosis and Hemostasis Network, or ATHN, the US-based organization that collects anonymized demographic, clinical, and genetic data from thousands of patients through a national database. In partnership with research groups, ATHN created several smartphone apps that patients can use to assist treatment, reporting, and management. The ATHN Robust Health app tracks bleeding events and treatment and generates reminders. Patients can promptly share information with their treatment center and track personalized goals. Similar technological advancements are available outside the US. In addition, ATHN can survey users and obtain important patient-reported outcomes through ATHN Pro. MyWAP's Hemosystem is a web-accessible population pharmacokinetic service that generates PK profiles with limited time point entry. This global network comprises approximately 591 centers and includes over 10,000 patients. The system supports personalized treatment by providing real-time estimates of factor levels. Artificial intelligence describes the use of machine learning algorithms and software to simulate human reasoning in analysis and interpretation of complex medical and healthcare data. A chatbot is a computer program that simulates and processes human conversation, either written or spoken, allowing humans to interact with digital devices as if they were communicating with a real person. Chatbots can be utilized to assess the user's health status and, based on the symptoms, provide actionable recommendations, as well as supporting education at a distance. Ultimately, the use of chatbots, databases with artificial intelligence, and ultrasound monitoring and interpretation may be leveraged to support patients with bleeding disorders to improve outcomes. In addition, early prediction for those at risk of poor outcomes is critical to leverage needed resources for intervention. These technologies may help overcome barriers to care and ultimately improve healthcare access. In summary, basic research scientists and clinical investigators, in collaboration with patients and families, government and advocacy agencies, and manufacturers, have provided the fruitful foundation for hemophilia treatment centers to effectively deploy innovations in therapy and technology to advance hemophilia care and improve outcomes. Despite all these amazing advancements, there remain issues related to equalizing care, including racial and ethnic disparities, issues related to women's care, infants, and the elderly, and adequate hemophilia care throughout the world. We have witnessed quantum leaps in care, innovation, and technologies, yet more remains to be done. In 2022, 75% of patients worldwide did not have an adequate supply of replacement therapy. Even in countries with the highest healthcare resource levels, biases exist that impact outcomes. Racial, cultural, and ethnic background, primary language, educational level, financial barriers, and gender may all influence access to care or provider perception, impacting diagnosis, education, and treatment. In a time of so many advances, it is important that every global citizen with a bleeding disorder be supported to obtain adequate care and reach their personal goals with a high quality of life. Thank you.
Thank you very much, Dr. Shapiro. And since we are in the very last webinar of the year, I put on my festive hat, which is blinking in and out of my virtual background. So sorry if that's a little psychedelic. But thank you very much. So that's a really interesting presentation, and it's exciting to see so many advances in so many different sorts of molecular mechanisms, and then also different exploiting different technologies. So really, really quite exciting, I think, to see all of that. I'd like to remind our audience that if they have any questions for Dr. Shapiro, you can put them into the Q&A feature at the bottom of your screen, and we'll do our best to answer your questions. Maybe I can start with one question. You mentioned that there are a couple of sort of newer generation bispecific antibodies that might be quite interesting in the hemophilia A realm.
Yes.
I'm going to ask you crystal ball. What do you think? Should both of these be approved? How might that, what might that mean for the management of hemophilia A? I mean, emicizumab is quite well established. We've seen, you outlined what it's doing quite effectively. How would two new players in that realm change that, do you think?
Well, I do think that each agent has a different specificity and some different things that could make it attractive for patients for their care. So for example, MyMate uses a small pen. Novo is very well known for their insulin pens with very small needles, so similar pens can be used. It also has tiers of weight-based dosing, so it does prevent wastage of the medication. It also has a different affinity towards its targets. So based upon what's administered, you could target perhaps different levels of assumed or mimetic activity compared to what you might expect with factor VIII. The second generation emicizumab is targeting actually different levels of thrombin generation or what might be, again, kind of a assumed level of factor VIII, even achieving that perhaps in the normal range. So, but those studies are not as far advanced as the MyMate study, so a little more data needs to be made available. So
Right. Yeah.
they
Yeah.
are advances.
It's interesting because it seems like there are some factors there that are going to be really important in making the right choices that maybe we don't know all of them yet. Are they things that are being shared widely, or how do you get access to this information? Like I didn't know about the pen. How do you hear about these things? How do you keep up with all of this?
Well, luckily we're participating in the trial, so we do know some information, but much information is presented at meetings.
Mhm.
So for example, at ASH, there were some recent updates. At ISTH, there were some updates, so
Right, great. And
look for data.
I guess we need to, have you come and talk to us every once in a while on Wednesday webinars so you can tell us everything that you're hearing.
No, there's lots
Uh,
of people.
Well, and I guess it also leads to another question, which is with so many options coming and some even already on the table, how does shared decision making play into this? How do we do shared decision making right with people as these options expand?
Well, that's a very important question. And I think what's really important is the dialogue that occurs. So it's it's not talking at someone and telling them what's best for them. It's finding out what their goals are, what they feel is best for themselves. Um, there are individuals who love factor VIII mimetics, for example. There are some individuals who prefer factor concentrate. And there is also the ability with factor concentrate, for example, to achieve a peak level, which can be very important for some individuals who are very active, lead a
Mhm.
very active lifestyle. And the new, longer, very long lasting factor VIII therapy can be very helpful in that regard because it's very predictable pharmacokinetics. In terms, I think really for each patient, what are their goals? What's easiest for them to administer, to adhere to? What's their lifestyle like?
Right,
What do they think of their present medication? What are their current issues that they need to deal with? All of these things are important. It's
right.
a dialogue.
Yeah, I think that's the word, isn't it? Dialogue. It's very much that I think the WFH shared decision making tool has a really great first step, which is really explicitly stating the priorities of the individual and making sure that everybody understands what those are. Because sometimes I think we think we know what they are, but maybe we don't
Yeah.
all say it explicitly. So,
And the other question is, many of the patients who walk through your door are already on some therapy. And the
mhm.
question is, how are you doing with that? How do you feel about that? Is it meeting your needs? Is it not meeting your needs?
Right. Yeah.
Another thing I want to mention is, treatment for patients with more severe disease has really advanced. I will leave out the hemophilia B with inhibitor population from that group because they still have some very serious unmet needs that perhaps can be met by some of these other rebalancing agents. But for other individuals with more severe disease or a more severe phenotype, the use of prophylaxis has become widely available and tailored, and they're doing pretty well. And I think what we need to really think about now is who are we leaving behind? We're leaving behind many moderate deficient or mild, lower mild deficient individuals, women with hemophilia who have difficulty with bleeding with menstruation. And how do we treat them more effectively so that we equalize their care as well?
Right. Yeah. So that there's a couple of questions actually that I'd like to ask about that. One is, for example, I believe the two gene therapies that have been approved for hemophilia, the indication does not exclude women, but are women with hemophilia getting gene therapy? Is that happening? Will that happen? Is there?
Well, I don't have all the data of who's been treated worldwide, but there are some women who could qualify based upon level and prior treatment. I
Okay.
think many women whose factor levels are not in the more severe range, who are not on prophy, may not qualify. I think that really depends on a conversation with the insurance carrier for that individual, which
Yeah.
different than Canada, the US is.
Yes. And maybe another population that we should talk about, actually many populations that we should talk about are people with bleeding disorders other than hemophilia. And one example that really comes to mind with your discussion about, prophylaxis being the standard of care in VWD, it seems as though it's sort of the opposite. The thinking is that you have to bleed enough to eventually get prophylaxis, as opposed to in hemophilia where the thinking is give the prophy before they bleed enough to do any damage. So is it possible in some cases advancements in care might be just changes in paradigms, changes in ways of thinking?
Yes, I think so. And I think for some of these things, we need to collect more data because, for example, the approval for the agents was based upon specific data sets. Insurance carriers in our country often use that data for approval for a change in therapy. If that data set doesn't include other outcomes or different regimens, then it may be difficult and you may have to really go to bat for somebody based upon their specific clinical issues to obtain what you think is best care.
Right. So we've got an interesting question that's come in on our LinkedIn event. Somebody is asking if there are any studies using AI to predict who is going to bleed or not. So for example, in women, where maybe the correlation between factor level and bleeding phenotype is not as clear as in men, are there any studies attempting to use AI to improve the ability to predict that sort of thing?
That's a very good question. Not to my knowledge, but that does not mean that it's not being done.
Okay.
There are countries that have more organized national databases than the US does right now, that could possibly leverage those to look at that. I think the US is a little behind in that area.
And with technology and AI, is there any concern about privacy issues? If you're working with a chatbot and you're providing personal data about your health, are there safeguards in place to make sure that that data is properly stored and protected and private?
Yeah, the chatbot that I referenced in the talk that I know exists is being utilized in Africa, does have safety profiles, safety mechanisms in place to protect people's identity.
All right. Yeah.
And it is really important for some of these countries. People live at a great distance from a treatment center. It's difficult. Telephone, computer access can be difficult. And so having something like this can really help them, and their local or national treatment centers are aware of it and aware of the information that's being provided.
Yeah. Yeah, it seems we had a talk earlier this year about telemedicine and the potential that it offers, but it does also raise a counter question as to whether some of the barriers that you mentioned to access to care, whether some of those same groups have, for example, less access to broadband internet or maybe smartphones or the sort of technology. And is there any risk that some of these opportunities to expand access might also sort of exacerbate some of the existing barriers to access for some groups of people?
It's definitely true. For in the United States, in my state, in Indiana, we have a large, what we call plain population, or also referred to as old order Amish. These individuals don't have cell phones, don't have telephones at home, and don't have computers. So doing telehealth with them, we've found ways to do it by
Okay.
having nurses embedded within communities with iPads and bringing the iPad to them to utilize.
Okay. Yeah, that makes a lot of sense. I know I was speaking with my father about trying to use some smart technology, and at one point he's just like, "Nope, I am not going to use that." So
Yeah,
it's
yeah,
not
but
for
the
everybody.
individual has to agree to do it. You know,
Yeah.
if they don't have to travel to see us, that
Yeah.
is an enticement for them.
Yeah. Yeah. That's great. Another question that I have maybe about the gene therapy. I noticed that people with inhibitors or a history of inhibitors were excluded from the existing gene therapy indications, or certainly from the trials that were used to
The
get to the.
original trials that were used to,
Yeah. So what are you thinking about whether people with inhibitors, are they eligible? Are they likely to be eligible? Is it a
well,
good idea to
there
try
is
to
a
get
study
them?
going on for factor VIII deficiency with the potential of looking at tolerization um, for gene therapy with inhibitors, but it's not available right now.
Okay. Is that something that might be less probable in hemophilia B? Because I know that the ITI is more challenging in hemophilia
Yes,
B.
yes.
Yeah, that'll be interesting to see what comes out of that study. And what about liver damage? Some people with hemophilia who've had maybe HCV or HIV infections might have some liver damage. Is there a point where that can impact their eligibility for gene therapy?
Yes, yes, and that's exactly what I was referring to. The amount of fibrosis or liver damage you have can
Mhm.
impact your ability to get a good result from the agent. And you really have to, look at that carefully and talk to the individual to make sure they understand. I mean, there are levels of liver fibrosis where it's not recommended.
All right. Yeah. Is there Is there a future where a gene therapy may be developed that is available for populations that are currently excluded? I mean, I'm thinking partly, I guess, about children. You could argue that children should be the ideal candidate for gene therapy before they have any
There
damage to
are,
the knees.
there
And
are studies, there are avenues that are looking at that.
do you want to tell us anything from your crystal ball about what you think might happen there?
Well, I think we need more work there. We need clinical studies and more data.
Yeah,
Yeah, but they're intriguing,
yeah.
at least from a scientific standpoint. It looks, it looks intriguing.
Yeah. And again, maybe stepping outside of hemophilia, but what about other inherited bleeding disorders? I suppose there are other sort of specific clotting factor deficiencies where gene therapy might be, at least logically, quite an attractive approach, but it's not really happening, is it? I don't think that there are. Are there any
It's
clinical trials for other gene therapy and other bleeding disorders, inherited bleeding disorders?
um not that I'm aware of right now. I think factor VIII and IX are the main targets. There are certainly gene therapy trials for other inherited rare disorders outside of hemophilia. So
Mhm.
it's clearly possible. in some of these other bleeding disorders, but not right now.
Yeah. Do you have any thoughts about what might help to give that a push? Is there anything that any kind of a development or I don't know, an advocacy approach that might increase the likelihood of those sorts of clinical trials coming around? Because, I think some of the other inherited bleeding disorders have far fewer treatment options than hemophilia as well. So it's
Yeah.
arguably a more urgent need.
I think some technologic advances could be used that, so if they try them in hemophilia, so for example, ex vivo transduction and reintroduction of those transformed or transduced cells could be possible for other disorders, but each one is very specific and needs to be tested clinically. So more data, more time.
More data. Yeah, great. Well, thank you very much. I really appreciate you answering all of our questions today.
Love your hat.
Thank you. Thank you. Thank you very much to everybody in our audience for joining us today. This recorded webinar will be available on Friday, December 22nd at hemophilia.org under the Events tab. If you select Past Events, you'll find all of our archived webinars there. This was the last Wednesday webinar of the year, and we will take a little break now for the holidays, but don't worry, we'll be back next year with a whole slate of exciting new presentations. Join us on January 10th for a look at recommendations versus practice, physical therapy at HTCs. Thank you for joining us this afternoon and this year. I wish everyone a restful and joyful holiday break and looking forward to seeing you again in January on the 10th. All the best.